Word. Yeah.
All right, good morning, everybody. My name is Ulysses. I am the Director of Business Development here at Amici Hospice. I want to thank everybody for coming in for this in-service slash training today. We are going to learn a lot today. I know that a lot of us do work and have worked at previous hospices, but as you guys know, every hospice is different. Every hospice has a different way of doing things. And we just want to go ahead and refresh your memory and let you guys know, our process of doing things here. This way, this is how we've kind of been accustomed to doing things and how things seem to run smoothly for us and the kind of the structure that we prepared, right? So with that being said, like I said, I do want to thank everybody. I want to go ahead and just basically start off by giving a quick introduction of, all our staff and positions. Maybe you guys are not aware, but we have, our administrator, Victoria. We have our DPCS, our Director of Patient Care Services here, Ms. Seaham, who is one of our main nurses. She's also an NP. We have our designee as well, which is Mr. Rod, very knowledgeable. Both are very knowledgeable as well, have been in the business for many years. We do have Kevin, who is HR, as well as scheduling, as well as everything. He's very hungry to learn and continue to grow. We got our office manager, which honestly, I think that title there is just, she does so much more. Myra is our office manager. She is our go-to. She is our lifesaver, just like Ella is a lot of the times. She's our go-to. If we don't know, she'll figure it out. Ella, our clinical care coordinator as well. We want to, shout outs to Ella. She's in charge of, providing, coordinating the care, DME, supplies, medication, making sure that there's communication. These are some of our main go-tos, right? We also have Araceli, our social worker with the Masters of Social Work, and amazing. I've worked with Araceli previously. Families love her. She's very knowledgeable. She's also our go-to, and she proved it last night. We needed something fairly quick. She came through very solid, helped us out. Family was very happy, and we're very happy to have everybody and be part of the team, right? Welcome, guys. We also have, obviously, different positions. We have our chaplains, we have our volunteers, people like Daisy, chaplains like, Kenneth, Alan, Don, Daisy. These are all amazing groups, guys, and I just want to let you know that we have a great team here. We really do have a great team here, and the only way this is going to work is if we all work in conjunction and together. I mentioned this earlier. Amici is not, it's not the owners, it's not admin, it's not DPCS. Amici is all of us. We come in as a team, and if one person doesn't do their job, it trickles down. And I don't mean do their job, but doesn't do their part of what the team is required to do, then it all trickles down. And it's not about, oh, they look bad. It's, we all get a hit for that, right? So we want to make sure that we understand what each person does, what we're supposed to do, how we communicate, and this is what this service is all about. I kind of want to start off with basically, initially, guys, how we actually get our patients. And this way you guys have a quick understanding of why we depend on you guys so much as far as making these calls, being prompt, notifying the family, right? So me as a director of business, my job is to go out and talk to doctors, talk to facilities, talk to anybody that can refer hospice patients. Sometimes it's not just going in there and getting them. It takes work. It takes convincing them that we are the company, a quality company for them. It takes convincing that we do have the qualified staff, that we are covered in their area, that if I'm going in there and promising quality, I got great nurses, I got great HAs, I got a great office staff, I got great directors, that when I make these promises and they actually sign on board, that my team does what they're supposed to do, because sometimes it takes months to actually get these people on board. And if they finally give me one patient to work with and then we drop the ball immediately, then this is like, oh man, you've been trying so hard to get, now I give you an opportunity and you didn't keep your promise, Ulysses, right? So after a lot of hard work, negotiations, and convincing the family, the doctors, the facilities, the hospitals that we are the right choice, we get the patient. We go assess whether we get the hospice order or we go assess with the doctor. We go assess. I want everybody to know that the first 48 hours are very crucial and very important in the admission process. Why? Because this is where we convince the family that we are that quality company that we said we were, that we are attentive, that we do get that DME and supplies there on time, that we care, and we care about their family members. We got to remember that at this point of the care, they're losing a family member, right? Or if the patient is actually, alert and oriented, they know that they're in the process of passing soon. So we want to make sure that we're compassionate, that we have empathy, that, we're sensitive to their needs, cultural needs, emotional needs, spiritual needs. This is where everybody comes into play, and we make sure that we cover all of these bases. It's very important and very crucial that within the first 48 hours, our admitting nurse comes in and does the RN initial assessment. Whether it's CHAM, whether it's Veronica, and this is totally different from an LVN tuck-in. The LVN tuck-in or even HA tuck-in or RN tuck-in. The tuck-in is where we come in, we just make sure that the patient comes in, they're greeted at home when they come home from the hospital or the facility. We have all their needs, kind of like pre-initial admission. We find out, we kind of get everything ready and try to gather up all the information for the RN to come in and facilitate the admission process. We want to make sure that we let the family know that the nurse will be there in 48 hours or less. We want to make, this is for the tuck-in, we want to make sure that we let them know the nurse will be there in 48 hours or less. We want to make sure that the family is aware that at that moment our care starts. We have a 24-hour nurse line. They can always call. There will always be somebody answering the phone. We're bringing security to them and peace of mind, knowing that even though it takes 2 days, it could take up to 2 days for the nurse to get there, but we still have that safety net that they can give us a call, whether it's 2 in the morning on a Sunday or 2 in the afternoon on a Tuesday. Give us a call. Let us know if you need something. This is where in the tuck-in, this is where we find out and start facilitating things like something as simple as diaper sizes. Okay, we let Ella know, Ella, we're gonna need some large diapers for this patient. Patient is bedbound, so it might be a good idea to get a low air mattress. Patient is bedbound, so they're gonna need bed baths, so we're gonna need water basins, we're gonna need body wash, we're gonna need some chucks, right? All of these things. This is where we come in and start observing. We want to also let the family know to bring out all the meds. Bring all the meds out. When the tuck-in comes in, not only do we want to have consent signed, and this is usually taken care of prior to it, because if we show up for the tuck-in, that's because most likely they've already signed consents and approved to the service. We want to make sure that all meds are taken out. We let them know. Even if they're not taking it, they were taking it a month ago, but for whatever reason you stopped taking it, bring it out. Let me see it. Let me see what you guys got. Inside, we always should have a binder on us, right? Even if you're not the admitting nurse, even if you're a tuck-in nurse, so you don't do tuck-ins frequently, it's always a good idea to have a binder on you, just in case, because patients do go to the hospital, they'll come back, we need a new binder, we need to make sure that everything is brand new at that point. Okay, so it's a good idea to grab a binder before you leave and have it in your trunk. We have a binder that should be at bedside upon tuck-in. Inside the binder, there's an area for medications, bedside medications. You want to help your nurse out? It's probably a good idea to start writing these medications inside the binder. This is very important, guys, because this binder is used in case of emergencies. God forbid we lose light, we don't have internet access, we have a natural disaster. This binder is very important because this is where the family, and we instruct the family member, if there's any natural disaster, any emergency, you take this binder with you, you give it to the ambulance, you give it to the fire department. This information here says their medications, frequencies, dosage, if there's any allergies, contacts, all of these things, everything is in this binder because we can't rely on internet or electricity at all times. And this is what the binder is necessary for. Not only that, it's also used for survey, which is another topic we'll get to in a bit. But when survey comes in, Department of Health, whoever it is, they're gonna come in, they're relying on this binder to make sure that it's updated. This is one thing that they're really hard up on. I've been doing hospice many years. I've been part of many surveys, and believe me, they will look. They will go page through page, making sure everything is updated. They will compare medications at bedside to what's written down inside the binder, or even some of the compliance paperwork that's inside. This is why we stress the binder so much, because it's not just a folder that we put away. It is something that is required during survey. And I've been in a position during surveys where I'm right next to the surveyor and they do have the binder, and they will say, okay, I don't see this medication, where is it at? Why is it not here? Why is it not in the MedRec? Why is this expired, right? So the binder is very important, guys. It's always good to make sure that it's updated, and it all starts with us on the initial tuck-in. When you put all the information in there, this is where we make sure that we get off on the right foot. Medications. And it's going to be empty initially, but you let them know. As soon as the RN does the initial assessment, then it's going to start getting chunky. We're going to start adding the plan of cares in there. We're going to start adding the HA assignments. We're going to start adding, whatever it is that we need, more information, the post, face sheets, all of these things. So this is why we really stress on the binders, guys. Miss Araceli?
So just like something that I like to remember is the binder at home is our Hospice MD there. So it should match exactly what we're going to put in Hospice MD. It should match the binder, which is why it's very important that everything matches, like you sign in the visits and all of that, and make sure everything is updated, because if they go out there and they find something doesn't match, we're going to get dinged for it. So just think of it that way. Just think of it like, okay, the binder is my Hospice MD at the patient's home.
Perfect. Perfectly said. Everything I'm telling you and everything I'm asking you to do is not something that I haven't done. I'm out there in the field as well. I'm out there doing everything that I'm asking you folks to do. So we're not just delegating. Believe me, it's all part of the process, right? So binders is very important. This is why we ask everything is updated. If you see any information that is missing, I need last name, first name, start of care, diagnosis in there. We handwrite it and we put it in there. Like I said, because we are handing this off to the next person, to the next, first responder, whoever it is. They need to know this information, and it needs to be very clear. Not only that, I want to base our service off of quality. I want to make sure that they see Amici and everything is filled out how it's supposed to, compared to other binders. I've worked for other hospices, or I go to facilities to where I see their binders, it's empty. There's nothing there. Nobody's signing it. You wonder if there's anybody visiting in there, right? And it's just like, what hospice is this? I do not want my family member being part of that hospice. Compared to the Amici hospice, look, everything is filled out. We got the allergies, we got the name, we even got sign-ins as well that are required. Now, once again, these sign-ins are very important. Every visit, whether you're the social worker, whether you're the RN, whether you're an HA or chaplain, it is very important that we sign in, because this is a way of proving to the Department of Health that we were there. Just because you document on Hospice MD does not mean that we made the visit. Anybody can document from home. There's no proof that we made the visit. So when that comes into question, we can pull out the binder and say, I'm sorry, buddy, look, I was there. I did sign in on the 25th. I was there at 2 o'clock. I gave a quick brief note, and this is my proof here because the binder is at the home, right? If for some reason, after you start making your visits, I don't want to sway too far from the tuck-in, but either way, since we're talking about binders, if you start seeing that information is missing, that people are not signing in. I need you guys to take initiative and be leaders and go ahead and communicate with your team, because each patient does have a care team, which includes RN supervisor or case manager, LVN, HA, chaplain, and social worker. This is the team that's in charge of this patient. You guys need to know who everybody is. I really encourage you to reach out to your HA, introduce yourselves, and say, hey, my name is Shernice. Is this Maria? Hi Maria, this is Shernice. Hey, just wanted to let you know I'm the LVN for this patient. Look, if you see anything that needs attention, anything that might require, me to advise you on, or a rash, a cut, a bruise, confusion, this is my number. Reach out to me, shoot me a text, or put it on Slack. I just wanted to introduce myself, let you know I'm here for you, and you got my support. And it goes a long way, believe me, because if you have your coworkers back, they will have your back. And this is how it all works. It's teamwork, right? Instead of putting anybody on blast or anything, they're gonna reach out and say, hey, Shernice, we need a refill. Patient this and that, or they haven't had it for 2 days. I know they forgot to tell you, but I just noticed. So, and this way we take care of each other and we do build that bond, right? This is what we need. This is what we need. I know sometimes we might not even be aware who our HA is or who the case manager is. I need you to start building that relationship with them. On Slack. This is the whole reason that we have Slack, so you can communicate. I want you guys to understand that communication consists of your care team. It's not about notifying the office to notify the RN. It's about communicating with your RN case manager or your LVN, and the LVN communicating to the office. It can't be the other way. You need to go directly to your care team, not go to the office and throw it on them and expect the office to communicate everything else. We need to build that bond and take care of our patients. You guys know that we should be tagging Myra, honestly, for pretty much everything, because she is one of our core here, and they always ask her. She knows everything. If she doesn't know, she'll find out. But when she's tagged, she looks at it, it goes up here. Next question, she has an answer for you. Okay, so Myra's our office manager. She should be tagged for everything. Another person that should be tagged for everything is your case manager, the RN in charge of this case. They need to be aware. If something needs communication, immediate communication, tag them. If you don't get any communication fairly quick, then feel free to reach out again and just say, hey, hey, Siham, did you get my message, or were anything? Just to make sure that we get prompt response and prompt care. This is what we're about: symptom control and comfort care. If we wait on an answer and it's 3-4 hours, those 3-4 hours are very painful for the patient while we're trying to get pain medication, while we're trying to get some kind of DME machine that they might need, supplies, anything, and it's a waiting game, right? Our job is to bring comfort, care, and symptom control ASAP. So we need to make sure that we do our part and communicate and follow up. If you put in a request for medications and you don't get an answer, feel free to reach out to Ella again. She's on your team. She's going to make sure. You got to remember that sometimes the team is busy. We have a lot of patients with a lot of requests. So sometimes there's a chance that it could get overlooked. There's a chance that maybe they do take care of, or they have taken care of it. They just haven't let the nurse know on Slack. But we do need some kind of confirmation to make sure that it's been taken care of. Hey, Ella, were you able to get that order in? And she'll let you know, yes, I'm sorry, I was taking care of this death call. Order's been placed 2 hours ago. Thank you. I don't want to say 2 hours ago, but we should follow up sooner. But just make sure that we follow up, because it's very important that we bring that care as quickly as possible. Communication, like I said. Speaking of communication, when you're with your patient, remember, these patients are passing. They are going through depression. They're going through anxiety. There's so many things that we really have no idea what they're feeling. So we want to come in. I need you guys to make that difference. This is where our quality of care makes all the difference. Come in, smile, represent Amici correctly. You guys work for a great company. You guys work hard for your positions. RNs, LVNs, social workers, whatever it is. Walk in there proud. You know, you're there to help. Hey, good morning. How you doing? How you feeling? Spark that conversation up. You know, they don't have much time left, so you want to make that difference. You want to make sure that they're happy to see you. They feel relief when they see you. They have peace of mind. You'd be surprised how much you can learn from a hospice patient. They've been through so much. We you know, a lot of history we don't know. Their culture. Like I said, I've been nursing a lot of years, and I've learned so much from all of my patients. And it makes a difference when you just spark up the conversation. Next thing you know, you're like, "Wow, really? You did that? You invented this? It's like, you never know. You know, just be a difference maker. You guys got it. There's a reason that we chose you to be part of the team, because you guys stand out more than the next person applying. You know, and we see the potential. Sometimes we gotta polish it. I understand. We have patients. We work other jobs. It's hard. We got families. You know, we got our own personal problems. It's just life. I get it. But when we go see a patient, we gotta leave that at the door. We come in and we make that difference. It's gonna make you guys feel good, believe me, makes the patient feel good, and it can make somebody's day. You walk out of there, you made a difference, and you know, you're able to sleep at night. There's a reason we became nurses, to help people and make that difference. I do not want to be a company that comes in, does their job, there's no connection between the patient or the family member with our nurses. We come in, there's no sensitivity, there's no compassion. We come in, and we're out. All right, see you in 2 weeks. That's not who we are. That's not the kind of culture I'm trying to build here. We're trying to build here. We want to make sure that we make a difference, right? That they say that they're able to refer us to their family members and say, these guys are good. They're very nice. Yes, sir.
There's no sound in the meeting.
Oh, everybody left. It's just us.
Oh.
Yeah.
Fee was on there.
Yeah, she was.
Okay.
Okay.
So this is the kind of company that we want. The only way we're going to continue to grow and get more patients and get a bigger paycheck by having more patients is by us actually putting in the work. If it becomes just a natural process to do these things that we're saying, it's not even work anymore. Because you're doing it with every patient. It just becomes a habit to where you go in, you do your job, you're nice, you're compassionate, you walk out of there, we start getting referrals, and our census grows. We're about longevity. We're not about, you know, making the quick buck and heading out. We want to make sure that our company grows for everybody's sake, and we all got bills, but the only way, you know, they're going to get paid is by putting in the work. We got a job to do. Let's make sure we do it right. Okay?
He's
Good.
trying to fix my camera.
Okay. No problem. So, this is all part of the tuck-in process. Also, once we're done with the tuck-in process, you know, medications, seeing what supplies they need, what medications they need, what else is required. Maybe we missed a DME. Maybe the patient likes to go sit in the sun, and if we're able to provide that wheelchair, you know, just go ahead and maybe ask them, you know, is this something maybe that we can provide? We're not in there. We don't use any of our equipment as a bargaining tool. We don't go in there and we don't say, hey, I can get you Insure. Hey, I can get you this. I can get you that. That's not what it's about. We've got to be professional. We go in there, we assess whatever it is that they need, then we offer it or we ask. We never make any promises that we can't keep. I don't know, but I can find out. Let me see if I can do that for you. Let me see if I can get that. No, we don't get scooters, but there's a possibility that maybe we can help out. Our social worker might know somebody. Our director might know somebody that works with someone with Medicare. Let me get back to you on that, right? So they're not, we don't make promises that we can't keep. Also, when we do make these visits, whether it's a tuck-in visit, whether it's a RN visit, whether it's a regular SN visit, we got to remember, guys, we are dealing with people's time, family's time. I don't want us to go in that same day or call the patient that same day and say, I'm 15 minutes away. I'm 10 minutes away. I can be there at 11. That's not respecting their time. That doesn't make us look good because they might have plans. We just changed it all up, and that puts an image in their head of like, oh, now I gotta stay for the nurses. You know. Let's respect our patients and our families' time, and things will be a lot smoother. I also don't want you to get a missed visit, because if you get a missed visit, then you don't get paid for the visit. I want to make sure that you guys go to the visit and provide the care, so we can pay you for the visit. Call ahead of time, especially if you know a family member is tough to get a. We come across a lot of family members that are hard to get a hold of. But if you guys know that this is an issue, then we have different options. Call and set a time where you would go every week at that same time. And it's hard to give a time, but maybe a window. Sir, I can be there. Is it okay if I'm here every Wednesday? You know, give me between 11 and 1. If anything changes, I will shoot you a text. But I will be here every Wednesday between 11 and 1. Or call them 2 days in advance. Even a day before sometimes, there's no guarantee. So with that being said, maybe call them on Monday. Say, hey, I'm planning to be there on Thursday maybe. Like, can we fix maybe 11 o'clock, 12 o'clock, you know? And maybe even then we can put, you know, sir or ma'am, if I don't hear from you, then, you know, I'll take it as a missed visit, or, you know, maybe we can see each other next week. But we just have to at least attempt it so that we don't miss the visits. Also, if we don't miss the visits, then honestly, you know, we don't get paid from the insurance for the visit. So we want to make sure that we do all the visits, so we have the most updated plan of care. There is a lot of subjects that we're planning to go over, and I don't want to bore you guys, but these are some of the stuff that we will be going over. Right, the tuck-ins was the first one. Would anybody like to add anything for admissions? Maybe Myra, Rob, that I might have missed for tuck-ins or admissions?
Did you go ahead and talk about like, okay, so one thing I do want to talk about that, the admissions is like consents-wise, if you guys could fill out everything, because there's non-Medicare items on there, so anything that's stable, just anything, and I know it takes forever in that pack, it's huge, but make sure you fill up on there, because I do have to upload the the non-coverage items. So if we could start doing those, as well as when we're doing, I don't know if you spoke about this, when we're getting a new patient information, like make sure we have, because Ella and I need it, the patient's name, date of birth, social always, because I do have to have that on the system. So let's start asking for socials as well. But other than that, yeah.
Correct. Remember, this is our first visit for the patient for the admission or the tuck-in. So we want to make sure that we ask who is the main contact. Who are we contacting in case of emergency? Is it a daughter? Is it a family member? Right? We also want to remind them, because I get it. We're not on call 24 hours, 7 days a week. That's not the job that we have. I mean, we are the nurse, and we are the nurse. But a lot of the times, patients are calling us on our personal phone at home. So, and that's okay. They call me all the time, right? But you want to encourage them and remind them. Any calls, anything that you need, call the office.
Yes.
This way it avoids delays, and it goes right to the person that needs to be notified, as opposed to giving me a call where I'm with the patient. I'll call you back. I'll forget to call back. I'll forget to text or whatever it is. Yes, sir?
In regards to signing the home binders, also be sure to sign into the facility if it's not a residential home, because they do cross-check with those visits to see when someone was there. If they don't have the home binder ready and they're calling the company, they just sometimes they check the sign-in sheet, so you should sign that.
Good catch, Rodney. That's right. So any signatures that need to be given, whether it's a facility, skilled nursing facility, room and board, boarding care, sign in at the door. Sometimes they require a temperature check. Ever since COVID, all of these things, right? But it's okay. You sign in, you sign the binder as well. Let's also be very mindful. I know that Ella will be posting the amount of supplies that we can give a patient per month. And this is very crucial. We are trying to keep a budget, guys. There's a reason that we do all of these things, because insurances do give a budget to go ahead and spend on the patient. So we got to make sure that we're not just giving stuff away where boxes are stacking up of chucks that they're not using, or whatever it is, whatever it is, they're not using the insurance, but we just keep ordering them on the monthly basis. We want to make sure that we educate the family at the time of assessment and initial admission about how much they'll be getting per month. We have to remind them we are a supplemental service. We're not here to take complete care of you. Unfortunately, that's not what we do. We're here for symptom control. We do have a 24-hour, 7-day-a-week service, but this is what we can do for you. Anything after the monthly supply, unfortunately, the family will have to take care of it. So I can give you, 1 case or 2 cases of diapers, but if for some reason you exceed that, folks, you will have to get that on your own. We will give you a month of Ensure. 28 bottles, I believe, come in a case, but if you need more than that, let us know. I'm sorry, not let us know, but you would have to purchase it yourself. Purchase it yourself. Education, like Ensure, is not to be taken daily. Ensure is only if the patient has a bad appetite that day and they're unable to eat. They're not getting all the nutrients that day. There's weight loss. This is when the Ensure comes into play. Education, education, education. The only time the family will know is if we actually educate them on why we do things and why it's important. Sometimes family thinks taking 2 or 3 Ensures is good for them. That is not the case. 1 Ensure a day is all you need to get all the daily nutrients and vitamins for that day. Unless there's tube feeding and the doctor orders more calories per day, then that's a different story. For the most part, it's just 1 Ensure per day, and it's only if the patient is not eating or losing weight. This way, the family's educated. They know that they don't have, if the patient had breakfast and ate a good lunch, there's no need for the Ensure. Give them water, give them a milkshake, but Ensure we can save. Ensures are expensive, guys, and the family will tell you this is why they're gonna come to us to order it. But they also have to know when to take it and why it's being taken, right? Same thing with supplies, whether it's diabetes supplies, any of these things. We need to make sure that that they actually do need them. We don't just want to order chucks if the patient is continent, if they're able to make it to the restroom, if they're able to go, have a bowel movement. They don't need it, right? They don't need a walker if they already have their own walker. We don't want to come in and say, oh, I can get you a better one. Don't worry about it. I'll take care of it. That's not what it's about. It's based on necessity and based on the health status of the patient. We're here to help, but we're not here to just have things on standby at the home. There's some things that are needed. Let's just say they feel like they need a wheelchair because patient has they like to go outside, like I said, catch some sun, or maybe the patient's current walker, it's just there's no brakes on it. It's lopsided. It's shaky. Then this is where we come and offer it. We just want to be mindful and conservative when it comes to supplies and let them know that there is a monthly limit. Now, there is times where the patient will have loose stool, episodes of diarrhea, and maybe for a month while we control it, while we get antibiotics in there, they might need an extra pack. And that's fine. I mean, we're not trying to be cheapos here. When it's needed, definitely. But if it's not, then let's make sure that we take care of our company, we take care of our budget. This way, if our budget is met, we have more money to take care of our employees and offer more, and even raises when the time is due, all of these things. But we have to make sure that we take care of ourselves so we're able to take care of you guys, right? You guys know that you got a great team here. Everybody's just a text away, a Slack away, even a phone call away. You will get the support. I've been working with a lot of these folks for many years, and they've always been there. It's just a matter of reaching out. actions speak louder than words. They will come through, believe me. And all you got to do is try it. They'll help you out, and you'll feel secure. You'll feel support, and you'll be happy that you're working here. Okay, all right. Now, that was for our tuck-in. That was for part of our admissions. So we went over all the supplies, making sure we call on time, making sure we schedule. Being mindful with people's time. Sign-ins, binders. Oh, one more thing on binders. Guys, if you see that after the first 2 weeks, there's no information inside the binder, we do have to be compliant. We do need a face sheet in there. We do need a care plan in the binder. We do need an HA assignment in the binder. And we need the most updated medications in that binder. Please, take the time when you sign in, go through the binder. Let us know if anything is missing. This is compliance. And something simple like that, missing something simple like that, can cost us a bad point, a ding. It's funny, and I've seen it, and it's not about the money, but something like that can cost you up to $10,000 just on a simple lack of paperwork being in the binder. And this is something that we don't need. We want Medicare to come in, or Department of Health to come in and say, oh man, these guys got everything. Oh, they got their stuff on point. It's not even worth looking into. They're already showing me that their binder is good. I looked on Hospice MD, I checked everything. They're gonna be like, easy job. But survey, they're paid to find mistakes. They're there to find mistakes. They're hungry for mistakes, right? So this is where we got to make sure that we're on top of our game. That's the whole point for them to be there. Make sure we're compliant and see where we're messing up. Because if they find a mistake on us, they get brownie points. Good job, Tina. You found these guys. Good job. They thought they can get away with it. Good job, right? And this is what they want. They want to make sure that they're known for finding mistakes. So we got to make sure that we're 2 steps ahead of the game. Not only it's not a game, but we're just compliant. If they come in, for example, I had a patient the other day. They gave me a call. I said, "Oh, go in the comfort kit. Bless you. Go in the comfort kit." They went in the comfort kit. Oh my God, Ulysses, the comfort kit's expired. When did it expire? December, which is not too bad, right? Go in your husband's comfort kit. It's a couple. Go in your husband's comfort kit. He should be there as well. They go in the husband's comfort kit. Okay, I found his comfort kit too. Oh my God, this one's expired too. I'm like, oh man. This is where MedRec and checking all of these things comes into play. Because if I was a surveyor, I'm not just dinging one patient. Now I'm dinging 2 patients for medications. And medication errors are some of the most caught mistakes during surveys, and they're most costly, and they're the ones that are going to haunt you the most. So I was like, wow, this person would have killed 2 birds with 1 stone at one home. We have LVN visits, we have RN visits, and we didn't catch it because we didn't check. And it's okay. This is why we're here, just as a refresher, as a reminder to everybody, because we need to be on top of it. We fix it now. There's no blame game here. It's just to empower us and make sure that we do it, because they will catch it. So we have to go ahead and reorder both comfort kits for the family, and we're on top of our game now. But it's not good. It's not good, And our whole point, why are we here? To bring comfort and symptom control in a prompt manner. And if we can't do that, then we're not doing our job. And if we can't find medications that are expired, then we're not doing our job. And like I said, this is everybody's job. Even HA can do this. For HA can help us, LVNs can help us, RNs can help us. If we make this part of our care, then we don't even have to think about it. It just happens naturally where it becomes part of our visit, right? At this point, it's very important for our RNs. LVNs could do it too, but we do have supervisory visits for our RNs, which happen once a month, if I'm not mistaken. It does take a little bit of time, and I get it, but it's very important to do the MedRec. We need to know, is the patient taking the medication? We are ordering it, they're getting refills, but if you really dig in sometimes, you'll see they're ordering lisinopril, but they're not taking it. They start stacking up on the side, they'll put it away. And we keep ordering it and ordering it. Survey comes in and says, okay guys, you're telling me that hypertension is controlled. You're telling me that they're taking lisinopril to control their hypertension. But when I came in during survey and I looked in the drawer, there's 5 bottles of lisinopril there. The patient is telling me that they don't take it because it makes them feel sick. But yet your documentation says hypertension controlled by medication. What medication are they taking if you got 5 lisinopril bottles here that have not been taken? This is where MedRec comes into play. This is why we should not be ordering medications early, because if we're on top of it, then there's no reason for us to request medications, have office staff call pharmacy to request it, pharmacy call office staff and say, what are you talking about? They're 2 weeks early. We still have medication for 2 weeks. Then the office staff has to contact the nurse. Hey, guess what? They're 2 weeks early. Then the nurse has to contact the facility to say, hey, guess what? There's 2 weeks. And it's just a whole waste of time if we do not do MedRec. It is very, very crucial and very, very important, especially since it is one of the highest errors when it comes to survey. So I need you to implement that on all your supervisory visits. Make sure that you do med reconciliation. This way we can tell if the patient is taking it or not. The doctor can make an educated adjustment and an order based on the information that you're telling them. All right. So yes, please guys, MedRec is crucial. At time of tuck-in, or on RN initial assessment, and every supervisory visit. It's a little tedious, and I know I've been there, but it needs to be done, because if not, then we're out of compliance, and we're gonna get dinged, and then they can shut us down.
Are we including supplements on the med list?
Yeah.
Yes, sir. Supplements as well. That's another thing. Thank you, Rodney, for bringing that up. We provide medication only. No supplements, no vitamins. On occasion, the doctor will order a certain supplement, iron, something like that. This is something that if the doctor ordered it for his care, we definitely will send it. But they'll say, hey, can you send me a multivitamin? Hey, I'm also taking vitamin D. Go ahead, can you send me that? I'm sorry guys, as much as I would like to, insurance doesn't cover that. This is something that is very cheap at Walmart. They're $2 or $3, I'm sorry, but this is something that we don't. Any medication, definitely, we'll get it here, and we'll get it here the same day. But no supplements, okay, unless ordered by doctor. Okay, another thing, go ahead.
Oh, sorry. I wanted to add on there. Let's say your patient does have a bunch of medication that was discontinued or added on. Just please let me know so I could just reprint you guys one and just pick it up in the office. It'll be easier. Or just cross it out, put DC the day of, so we don't get dinged, just in case. Because they like to do those surprise visits here and there in the patient's home.
Oh yeah. Thank you, Mara. Guys, also, on your SN visits, once again, the whole reason we're here is for our patients. Rapid symptom control and comfort care. Make it a habit. Actually, this is what's required. I'm asking you to do this. I need you guys to put in the order at bedside. If there's any medications that need to be ordered, any supplies, order them at bedside. We need to make sure that we do this as quick as possible. Don't wait till you get in your car. Don't wait till that afternoon. We can forget. We have so many patients, so many calls, other jobs, we can forget. The best part about providing quality care is being able to show the family we ordered it right then and there. This brings importance. They feel that they are important. They let them know that we're on top of our game. Okay, sir, Did you need any other meds? Okay, lisinopril and your aspirin 81 milligrams has been ordered. I just ordered it, sir. It's been placed at the bedside. Oh my God, thank you very much. I appreciate it. No problem, sir. You know that refills are due, will arrive next day. Any new orders will arrive the same day, but refills the next day. But at bedside. I know sometimes I'm seeing this. We're making requests at 8 o'clock at night, 9 o'clock at night. It's not fair to our office staff who is at home with their family. They've already put in their 8 hours, and now you're asking them to deliver medications. You're asking them to step out of dinner and go online and request these things when it could have been requested when you made your visit at 11 a.m. So make sure you order these things at the bedside. By the time you leave the patient, the only thing that should be required from you is your notes, which should be done within 48 hours. Okay? This is a must, and we're adamant about this. 48 hours. There's a lot of information that can be lost if you don't do it in 48 hours. You guys have multiple patients. You guys have multiple jobs. We can forget certain things. But if you do it within 48 hours, your mind is clear. You remember exactly what the patient said, why, what he was complaining about. All of these things, everything's fresh, and it goes right into Hospice MD. I honestly prefer that if I know it's hard because we're on a timed basis, but I mean, if you can pull out your laptop there, does the patient have confusion? No. Are any when was the last bowel movement? You type it in right there as you're talking to them, like you would at the doctor office. It's taken care of. And I'll give you a little tip. I mean, if you do have, text to talk or talk to text, that makes it so much easier. Maybe not at bedside, but even at home. You press it. Visited patient Mr. Smith. Patient is an 82-year-old, Hispanic male with a diagnosis of Alzheimer's. Patient is a low-oriented type. And it's just, you're just talking, giving your report, and just typing it out for you, but you might have to go back and fix a few things, but it makes it so much easier if you just use that. You get it, you knock it out of the way, and you're fine, and you're set, and you're compliant. Okay? So, 48 hours for notes. Order medications, supplies, everything at bedside. Now, the only way this is going to take effect is if we get the help from our employees, our nurses, our co-workers, right? We need to be leaders, guys, like I said. It's not about a title. It's not about who you are. It's not about what you did. It's about just implementing these things. Anybody could be a leader. It's just a matter of leading by example. And once they see, the HA will do it if they see their LVN doing it. The LVN will do it if they see their case manager do it. And the case manager will do it if they've been trained on it, right? So this is why we're here, because it's all connected. And the only way we can go ahead and make this is if we train you, we tell you exactly what our expectations are, what we need from our nurses, what we want from our visits. And if we're all on the same page, smooth sailing. Smooth sailing. You do have a great support team, so there's no reason why we can't be that great quality company that I know we can be, and we are. Just a little side note. I mean, we are. If you guys look at it yourself, we've been very blessed to be like one of the top 10 hospice companies in Riverside County. But I want to be more than that. I want us to be the top 10 in Southern California, right? And then you never know. We expand. Everybody has potential to be leaders. Everybody has potential to expand. And you never know. We all started with an opportunity. I could be asking Veronica, hey Veronica, I love the way you work. I love your leadership. Are you interested in taking care of the San Diego area? That'll be your area. You'll be a supervisor there. You control your nurses. You make sure that everything's on point. Let's negotiate. Let's talk. Let's see what we can do. You never know. Same thing with Shernice. Shernice, you're a go-getter, you're a hard worker. I see the way you communicate with patients. Do you mind? Same thing, taking care of San Diego area. Training. We want people to follow you. We want people to do things like you do. You're a great example, right? Possibilities are endless. We're all here to work together. We're all here to help each other, empower each other, and create that. I mean, I'm an LVN. I have inspirations of being an RN. I've worked with many RNs. I learned from people like Rodney. I learned from people like Seaham, and you know, like I said, it's not about your time. It's just about wanting to learn, being that sponge, sucking it up, and doing it. Anything is possible, and we could do it. All right. Anything I should add, sir, on what I've covered so far?
Sounds
Good?
so far, yeah.
Okay, sounds good. Good? All right. Guys, we are in the death business, right? Unfortunately. So it kind of gets to me when we have death calls and sometimes our nurses don't know what a death call is, right? And I get it. Some of us are new to hospice, some of us don't know, but this is why we're here. We're here to train, we're here to give you the knowledge, and you can take this anywhere you go, any hospice you go. I want to make sure that we increase your value as a nurse and as an employee, right? Death calls. You guys ready for this? All right. So, a death call is when the patient is at home and he's found obviously expired, okay? The family will call you and tell you, oh, I checked him at 12:30 and I checked at 12:30 he was alive. 5 minutes later he was dead, so I think he died between 12:32, 12:33. That is not the time of death, okay? A death call, what we do is, as a nurse, we show up to the patient. We check for vital signs, respirations, breathing, right? Pulse, absence of vital signs. We can, no pupil reaction. You open their eyes, you put the little flashlight in their eye. Pupil doesn't react, then most likely they expired. You can also, they're not breathing, no chest movements. Based on all your observation, what's all of this